Okay, good afternoon. Still see a few faces, so it's quite good to see a few dedicated people who are sticking around in Sunday afternoon. Dr. Ashish asked me to give you a summary or a perspective about the diagnosis and management of the infected TKR. And I must admit that you heard the masters of the single-stage revision, but this is not for the beginners. So you really have to know how to diagnose and how to do a two-stage revision well before you start wondering or a single-stage revision, because if your technique is not good, you will end up with a catastrophe. So, on that note, I would like to speak about the diagnosis and how we manage the infected total knee replacements in the UK. Okay, can I? Next slide. Yes. So, why the infection is a problem on the rise? This is the UK projected age structure between 2010 and 2035, and you can see that people, and I'm sure it's similar to some extent everywhere in the world, will live longer, so we will have a more elderly population coming in our way. I showed this slide before. We do more primary joint replacements. Inevitably, we will do more revisions as well. It doesn't matter how good we are, despite all of our efforts, infection after joint replacement is a problem and remains a problem, and it's roughly 1.5% in primary knees, and it can be as high as 10% in revision knees. Infection is revised, prosthesis is revised for many reasons, and number 3 is cell infection. But if you think that some of the pain also infection, it may be a bigger problem than you think. In the United States, 2017 paper listed infection as a number 1 problem for revision. So it is a problem elsewhere. Infection is very costly to treat, and this is a paper which projects the cost of infection in the US, and by 2030 it will be over $1 billion to treat infection-related joint replacements in the United States. It's not only expensive, it can kill us, and this is a study compared aseptic and septic revisions, and there is a 5 times increased mortality if you revise a patient for infected joint replacement compared to non-infected revision. This slide is from the Scottish Arthroplasty Registry, and this is the infection after TKR in Scotland. You can see the green light, just below 1% is the national average. You see a red light at the top. This is 2 times the standard deviation, and if you're above the red line, you're an outlier. And if you're an outlier, you have a problem, and you will be contacted at the surgeon level and at the departmental level, and they will ask you, could you please explain why your infection rate is so high? You can see the Golden Jubilee Hospital on the far red with over 16,000 knee replacements. I showed you this diagnosis before. Is just to re-emphasize that you need to know why you're revising, and the first thing that you have to exclude with every revision is it infected. This is the MSIS criteria, just to show you briefly. There are many systems, but this is the most common used. This has major and minor criteria, and it gives you the threshold for infection, 1 out of 2 or 3 out of 5. There are many classifications for infection. One is the least star one, but the more pragmatic one is the Trumpus classification, which basically says, is it less than 4 weeks or more than 4 weeks? And as you could hear from the previous talk, 4 weeks or just around 4 weeks is crucial, because this is how it longs to take to form a mature biofilm. And once you have a biofilm, you have a problem, and you probably have to remove the implant. This knee is probably quite obvious it's infected, so we don't need to ask why. For this case, you probably think it might be infected, and this is a good-looking knee, but in reality, all these cases are infected and they have deep infection. There is no ideal test, as Dr. Zahar showed previously, and this is just a brief summary of different tests. The ideal test would be 100% sensitive, 100% specific. It would be easy to do, it would be quick, and it should be cheap ideally, but there is no such a test. So there is no better place to go if you want to deal with infections, and I had the pleasure to spend 2 weeks with Dr. Zahar in Germany in the endo clinic, And our infection diagnostic protocol is basically coming from the endo clinic. So I will briefly tell you, similar to his, exactly we took this completely from Germany. You do the examination, history, blood test, CRP is important. We tend not to do ESR full blood count anymore. Joint aspiration is mandatory. And the culture is for 2 weeks. There was a presentation yesterday and they were talking about cultures don't show infection after 5 days. If you're at culturing less than 10 to 14 days, you will miss up to 30-40% of the low-growing organisms. So it's important that your culture should be long enough to detect most of the organisms. If you don't know after the first round, you can repeat the aspirate. You can use the very fancy, expensive Synovasure test. You can use a PCR, which is not very cheap, and you can potentially use bone scan or SPECT or other fancy devices. Mini open biopsy is done very often. This is a comparison of two tests, and this might be, if you don't use it so far, I would suggest you to use the one on the left, which is a urine dipstick. It costs pennies in the UK. I would like to think it's readily available here in India as well. And the specificity and sensitivity is comparable, but it's a price of 5 pence compared to £350. If you take intraoperative samples, it's very important that you have to take multiple samples. It's recommended that you take at least 5 samples. Every sample should be taken by the clean set of instrument. And after you take your samples, every sample should be sent in different sterile package. This is the setup when we do the samples, and you can see that there is a sterile container with a sterile set of knife and forceps to take all the samples. Dr. Zahar talked about the DARE procedure. We talk about the pre-treatment options now. So time is an essence. You have 4 weeks to do it. It's not a Friday afternoon surgery done by a junior surgeon. It should be done by an experienced surgeon, preferably with revision experience, and it should be done with the same principles as single-stage revision. And very often, this is the last chance to save the implant. If the DARE procedure doesn't work, the next operation is likely to be a 2-stage revision. The results with DARE are variable. If you read the literature, Oxford Group published very good results with outstanding series, 85% success at 2 years. But if you read the paper, it's done at semi-urgent surgery, so it's not done 2 o'clock in the morning. It's done by senior experienced surgeons with knee revision, and it's very often they do it together with very extensive 4.5 years up to 5 years antibiotic treatment. And you start wondering that is it really an eradication or a suppression. PGI treatment option, you should stop antibiotics for 2 weeks before you take your samples. We talked about the sampling tray and at least 5 samples, and you re-scrub and re-drape before you do the second stage if you do a single-stage surgery. It's radical, meticulous surgical debridement is the key. Antibiotic treatment can complement a good surgery, but it will not replace it. If your surgery is bad, antibiotics will not help you. If it's 2-stage or single-stage, depends on your training, depends on the countries, sometimes within continents. 2-stage is still considered as a gold standard, and more challenging cases are still done at 2-stage revision surgeries. You have to remember, however, as Dr. Zahar pointed out, that 2-stage revisions don't always account for additional spacer exchange or mortality. This is the sort of UK perspective. In the UK, around about 25% of the cases done as single-stage revision, so it's a lot lower than the endo clinic. And this is a helpful paper just to give you an idea of which are the potential patients who might be suitable for single-stage revisions. A healthy patient, healthy soft tissues, minimal bone loss, you know what the bug is, antibiotic is available, and preferably the patient shouldn't have a fistula. This is the two-in-one revision setup for the Golden Jubilee, which is similar, and we learned this from the endo clinic. You basically do 2 operations. One is removing the implant, the other one is the surgery with clean set of instruments, and the time between the first and the second stage surgery is 15 minutes. So it's not one operation, it's 2 operations done in one after the other. If you have an immunocompromised patient, if you don't know what the bug is, if you have significant bone loss, or you have a lot of problems with the soft tissues that may require plastic surgery, then you do a two-stage revision in the UK most of the times, and this is done about 75% of the time. The Macpherson classification is very helpful if you want to have an idea which cases will cause you the more problem, and it basically not only classifies the infection, it gives you a classification regarding the host and regarding the local extremity. The possible worst-case scenario is a C host with significant multiple compromising factors and an extremity with significant compromise. Mobile versus static spacer. This is, again, a never-ending debate, and there was a systematic review which basically compared a lot of papers talking about mobile and static spacers, and the bottom line is that based on the long-term results, no recommendation can be made based on superiority. If you know how to do it, it works well both in your hands. We talked about the fixations and the zonal principle. Cemented or press-fit stem. This is just an article. This is just one summary. For cemented stems, you have local antibiotic delivery. You can use it for poor bone quality, but you have difficulty removing it. For uncemented stems, you have better alignment, easier to move, but it's more technique dependent, and you may have a higher loosening. Just a few cases at the end. This is a lady, one of my patients, who had a scorpion knee replacement 5 years prior to coming back to me, was complaining of pain. You could see the osteolysis, and CRP was slightly elevated. It was a sensitive staph aureus, and we did a single-stage revision. This is the immediate postoperative X-ray, and you may notice this little white snowflakes, which is the stimulant beads. And the stimulant beads is getting more and more popular in the UK, and this is basically an absorbable calcium sulfate which gives you local antibiotic delivery. This is a two-stage revision case, a lady with next-gen knee replacement 4 years prior, went back to the surgeon, normal CRP, negative aspirate after 5 days, and this is the X-ray, and you see a catastrophic failure within a short period of time. The first thing you have to think about is this infected? So this was sent to me as an aseptic revision. We obviously repeated everything. The only high abnormal result was the cell count. Everything else was negative. Our diagnosis was culture-negative infection, and the intraoperative samples confirmed the staph epidermidis. This is the first stage. You can see that the tibial tuberosity looks very thin. Patella looks a bit high, almost as if the patient had a patella tendon injury, but it didn't. It's just how the X-ray presents itself. And the patient had a big problem with zone 2, and this is the revision with a hinged implant and the TM metaphysical cone for zone 2 fixation. Antibiotic suppression, Dr. Zaha talked about it. This is to control infection, not to eradicate infection, and it's only for elderly frail patients. Success rate tends to be low. Just a few more slides. And it's relatively contraindicated if you have other implants or if you have artificial heart valve. Arthrodesis, this tend to be used rarely in the UK. Good candidates are the young patients, and there are different methods: IM nailing, X-fix, double plating, and this is just a case. It came to me. An elderly lady operated elsewhere, had a quadriceps rupture, was repaired, had a re-rupture and developed an infection, and we used the Endolink from Hamburg cemented fusion nail with good results, and this is the 2 years post-op X-ray. Above knee amputation is the last stop. Thankfully, it's done very rarely, and it has high morbidity and poor mortality. So summarizing, I would like you to think of infection as a war, and this war is between the patient and the organisms, and you and your team are the only ally of the patient. And if you want to win the war against infection, you need good equipment, you need up-to-date knowledge, and you need to be well-prepared plan. And the key success to infection management is teamwork. Thank you for your attention.